I hope more men will attend this session. Uh, First, I wish to welcome all of you in this session. Uh, Let me tell you a story why I thought about this symposium. I am heading an orthopedic department of one of the big private hospital. So sometimes they give me application of a female specialist wants to join the hospital. I just for 30 seconds, I put the paper in front of me and I thought I will not hire her. And then suddenly I felt shame that just I think this way. I called the senior specialist. I said to him, this doctor wants to join you, and he told me it will be difficult to just communicate with her because we are sitting together in the room. We are discussing the way of distributing work to manage. So this is brought to me in like a minute that we may be not fair. Just we are going to our easy part. We wants to our friend, our colleague, rather than to include everyone. So I thought for this session, and I know very well dedicated female orthopedic surgeon, so I just hired her immediately, and I recommend her, and then this is bringing me this idea. Why you are getting the easy way to hire more men than thinking broad. I wish to thank Marwa Rafat. Marwa is lecturer of orthopedic surgeon in Alexandria. Marwa did the great effort organizing this session, and I want to thank Professor Adel Alawi for his support, Professor Beha for chairing the session. Margaret Fogt from Hong Kong, she is in SICO, and I read that she is keen on diversity in the SICO group, so I asked her just to give a talk, and Professor Nashad he will give us the US experience, and then we will hear from our women's their career, their challenging, and I hope by this end of session we put just a schedule or a framework just how to encourage, because when I talk to them, they have a feeling that they will not be accepted easily in the community. So I want just to highlight all these issues. No, they feel they may be false feeling.
Yes, this false feeling is an very old concept.
Yeah.
If we are talking about, allow me to say good morning, everybody. Good morning, Dr. Nashad. Morning, all the ladies who are attending this very important session. I was so keen to attend it because not only for the concept of women empowerment, the whole world talked a lot about women empowerment. And now it is a fact. Now we are talking about our specialty, orthopedic surgery. If we are talking about women empowerment, for myself, I'm with the side of women. I'm living in my family. I'm alone, and I have 4 females, my wife and 3 daughters. So they are.
This is natural discrimination.
Yes. If we are talking about orthopedic surgery, the old tradition, it is the old concept of that orthopedic surgery is a male-dominated specialty is obsolete now. Do you agree with me or not? Yes, I agree 100%. What is remaining for us is how we are going to make the maximum benefit for proper utilization of the skills and talents that the females have. Through a lot of that's what we should talk about. What is the plan to optimize or maximize the proper utilization of your talents and your skills in orthopedic surgery to add for our specialty. Okay? Yes, we are.
Thank you, Professor Hadi, for comment. May I ask Marwa Ras to moderate this session? We'll start.
One thing, Marwa, I have a comment regarding you. You told me that, what is your name? I was so happy to see the number of females attending this session. You called me Marwa Rafat. You know well that your father is one of our friends. He is a very eminent orthopedic surgeon.
Yes.
You should be proud.
I am proud.
No, you have to say, I'm so proud.
I'm so proud. All of us in the session.
Could I start first? I ask Margaret. Ras, would you please start?
Is it 6 minutes? Really? Okay. I thought I've got more minutes. Okay, so I'll try to rush through because I only noted that I've got 6 minutes instead of 10. So just a little bit about myself. I am the 10th female orthopedic surgeon in Hong Kong. So it's 7.5 to 8 million regions or cities in the south part of China. So I worked in the tertiary hospitals for over 20 years. I'm now a consultant and deputy chief of service of the Department of Trauma and Orthopedics and Traumatology of Queen Mary Hospital. I'm also the honorary clinical associate professor for the University of Hong Kong. So these are the things that I do. You can see that I'm involved in some of I'm a hand surgeon, so I specialize in hand and wrist. And so I've been involved in the Hong Kong Society, the Asia Pacific Federation of the Hand Society, as well as I am one of the founding member for the International Orthopedic Diversity Alliance, which I do encourage that you guys to join, and of which I was the Asia Pacific representative for the past 4 years. In the Asia Pacific Orthopedic Association, I am the president for the Hand and Upper Limb Society, as well as the CCOT. I'm the Education Academy Chair and the Deputy Chair for the Education Committee of the ESACOS, which is a sports society. So it seems as though that I'm doing quite a lot in different societies, and this is my CCOT experience in terms of what I did from 2008 to all the way now to here. So it's over 18 years of experience, of which I first noticed CCOT in 2008 when they have the annual congress in Hong Kong, and subsequently I joined the Young Surgeons Committee, and then I attended the meeting, and then I joined the hand committee, of which then I become the chair, and then I just gradually move up the ladder. So this is a picture that everybody like to see, is that I'm the only woman that in that EC committee, and then at least there's a woman there out of all the men, and so yes. Everybody liked that photo. They just oh yes, there's now a woman there. I don't know whether I don't really look at it that way. That's the thing. As you can see, that I never, for all the time that I've been in doing orthopedics, in the training, especially in training period, I never really thought that I'm anything different. I do need to think more about work-life balance in terms of whether you want to have a family, you want to have kids, and whether you're committed. And that is something that is more important. So this is something that that I do find that's the challenge. So this is the committee now. We've got more. We've got another woman, who's Anna, who's the Young Surgeons Committee Chair. So we are now getting a little bit more for the CCOT. But how do we get there? I think it's not because that, they want to have a woman in there. The challenges I feel that face for women is that we do need to think about how to balance it, and we need to be a little more committed. Very early in our lives, we need to know exactly what we want to do and how we proceed. I have a long-term partner. I've got a boyfriend who have got kids. I don't have kids, and so I'm able to travel a lot more than some of the other people. But that's by choice, and that's also my opportunities in the end. But this is how I choose to concentrate more on my careers. But I think that it's very difficult to strike a balance at times when you have families and as a Chinese, I feel like that we still have the expectations that we need to take care of our children. If we have them, we are the ones who need to take care of the family and be and so sometimes it is and you have the instinct that you should be the one who take care of them. It's not even about whether your husband or whoever your partner is able to share with you. You feel like you're in the instinct you need to take and glue everything together. So this is something that we have to decide and how we're going to strike it. So a lot of people said about leaders, female leaders, why we are not having a lot. I think sometimes it's not. We do getting more opportunities nowadays, but we feel that sometimes some of my friends who are very good leaders, they choose not to be the leader because of the family commitment, and that's completely fine. I think that we cannot just condemn someone. Why are they not being the leader and help? But they are choosing different ways, and this is something that you really need to decide as a woman quite early on to see which way you're going to do. For challenges, I do think that at work, before I have problems with patients, they think that, you're young, you are female, and they always mistaken you for nurses. I think it's getting changes nowadays. They need to be, so you need to be more confident in telling them that you are not, and that is something again that feels like the men, they have the men counterparts, they have less, they don't need to do that. But colleagues-wise, I actually have no problem because I come from a department where I'm the third one of the lot. So basically, when I came, there are other women there who basically they show me how to interact with guys, and I tend to be able to work with them without problems. Now the problem is about the boss. Is actually now is like when I get. So for training, I don't actually have a lot more problems. Now I have problems when I'm in a more senior position of where can I get. And sometimes men will now be fighting with you to get more aggressive in terms of saying that, could you, that they are now trying to say, you're just you're a woman, you're committed, maybe you shouldn't be in that position. So I have more problems now than before, but as long as which I'm going to talk about is, as long as you have allies and you have mentors, this should not be a problem. So you need to identify who are your allies and who are your mentors. Societies, there are different cultures. So for example, CCOT is a very diverse community, but there are different cultures systems that may actually affect how you do things. So this is the challenges I feel like that I have in terms of when I am now in the position overlooking all the education activities. I feel like that I'm being challenged all the times. I'm being questioned at times when they feel that, you look young, you are female. Why on earth are you ordering me around? So I feel like I actually need to commit more and deliver. So I need to prove to them that I am better or I can deliver. So this is something that I do think that it is getting a lot of challenge. Remember to identify your mentors. These are some of my mentors. You can see that most of them are men. And because we don't have that many female, and actually the men are not bad. You don't need to have a woman. I feel like that I'm a bad mentor at ways because I'm the one who will expect a woman to do much better. I will expect them to need to deliver more because I feel like that I need to be committed. I don't want them to feel that they can get an easy life. They need to commit, and I will support them if they work. So yeah, that's something about your mentors. Identify your allies. These are the ones who are giving you support throughout your career. You have drinks with them. And again, there's men and females, and these are the ones who basically give you support when you are down, and they are the ones who will give you advice and emotional support. These are the international allies that I have in CCOT. Again, you can see the president, you can see Jamal. These are the ones who actually will give you opportunities. Sometimes it's difficult. Sometimes I feel like that there are women who come up to me and said, I feel like I'm only given the opportunities because I'm a female. It's okay, just grab it. I think you still need to take the opportunities, but you need to know that you need to deliver. You can deliver, and you need to be committed, and you need to deliver. And that is something that is important. It doesn't matter when they're given the opportunities because you're female, but as long as they deliver, they will change their mind, and this will actually help for the ones who are coming in later on, because now they see that a woman can deliver certain things. So this is something that is important, and so don't just brush it off and don't say, oh, because that they're just using me as a woman, I should be lying there and not doing much. For the past years in my career, I feel like I'm trying to be more inclusive. Now I really want to be integrated. Inclusive basically means that I'm just trying to be, when I first joined as an orthopedic surgeon, I feel like I want to be a man, basically. I want to do exactly what they are doing. I want to be one of them. And so I try very hard to be included. But we now know that it's better to be integrated. So they don't really care whether you're woman. They think that you are just an orthopedic surgeon who are going to be, who can deliver and who be nice. So this is still a challenge that is coming into place. But but we are getting there. And so my advice for all the females is to identify your goals early. We do have a timeline in some ways, especially if you want children and you want a family. Seize the opportunities, no matter whether you think that is just because that they're giving you as a female or anything. Just seize the opportunities and commit and work hard and deliver. Don't think that, and when you are in the position, don't think that you have to give another woman opportunities. There's something slightly different that I'm not completely sure is pick on the ones that be fair and pick on the ones that who can deliver. It can be a man, it can be a female. If they are both, then yes, then you have to decide. But don't just pick on another person because they're female, because sometimes that will actually backfire on you, and that is something that I do think that is important for them to know, that because that will reflect on you that you are now biased, and that will be bad for the whole of our gender. So with that, thank you very much for listening. It takes a while for me to get into the front line of my department in Hong Kong, but it's a nice career. It's a nice a path, and I do enjoy it. So welcome to come to Hong Kong when you can, and thank you for the invitation.
Thank you very much, Margaret, for this presentation. And the floor is open for any question for Margaret about her presentation. But shall I ask you, you have said that you should identify your mentor.
Yeah.
Yes. What do you expect, what do you suggest to how we can empower women in orthopedic practice through mentorship? Do you advise to have a mentorship network, for example, where senior female orthopedic surgeons can communicate with juniors and guide them and help them how to find their way in for a proper education and training programs in orthopedic practice? Because as we know that now, as I have said, the concept of that orthopedic surgery is a male-dominated specialty is obsolete now. But the problem is how to have access to scholarships, to training, educational programs in orthopedic practice. I think that to creating such a mentorship network will be valid for that. What is your opinion regarding that?
Thank you. Very good questions. I do think that mentorship can be local as well as international, so it doesn't have to be just one as well. There's mentors who used to be my mentors who are now friends. So it really depends on different level of your training and your medical career. So most of the ones that I have that when I was young was are from my department, and they give opportunities, and so it can be men, as I said, it can be men or female. They give me opportunities and they will show the support. It may be nice to have a mentorship program where you do one-to-one, but then sometimes you need to switch because even though that you think that it's matched, they may grow up with each other, and then so at different times of life you have different kind of mentors. Internationally, we do have, for example, IOTA, they do have a mentorship program which we can reach out to women. Some of the women feel like they're more comfortable in talking to women. So that's something that we can. So now they see so if we don't have, for example, if you say Egypt, they don't have enough female mentors, we may need to reach out to internationally to see how they overcome some of the difficulties and anything that they feel that they can't work out. So yes, and CCOT is now also doing a mentorship program, a leadership program. So these are things that we can talk to other people, and so we nowadays with the internet is much easier. I think when I first joined, is that the internet is not as good, that we don't have a lot of Zoom calls, we don't have a lot of interactive sections. So we basically rely on the local a lot.
Yes.
I think especially in Egypt, having a female mentor is important because you need someone to look up to aspire to, or just to achieve what she has achieved, not be with the clinical experience. So I think specifically in Egypt, female mentors are very important.
Yes. Yeah.
Dr. Rashid, تفضل.
Thank you.
One big goal is the high demand of musculoskeletal injuries and the physical activity for a young female surgeons,
Yes.
especially in the orthopedic field. How would you manage this with the demand as well as the physical activity as well as the long hours of standing in theater?
Dr. Rashid, allow me to answer. Now, I disagree with you. Nowadays, most of the females go to the gym, they play gymnastics, they have more powerful muscles than males. There is no problem in the physical fitness at all.
Leisure time. Thank you.
I think there is hope in some women that that's tough.
Yeah.
Yeah.
But with the new instruments and
Definitely.
Yeah.
Definitely.
we don't need so much.
But may I ask you, if you are counting the number of attendees in any gym, for example, here in Egypt, for example, the males versus females, you will find the number of females are much more.
The number of gyms was
Males are lazy now.
No, I do think that I agree that it is tough, it is not easy, and so it's the same with surgeons. I mean, and so I do agree that they need to be committed. That's why I said I often feel that I tell my junior, especially female, that they need to be committed. It's not a smooth path. They are quite demanding, and so they need to train. So yes, they can go to a gym to do. There are certain things that we expect them to do, and some of the men will just say, "Oh, we'll help you," but it's not the thing. You need to do it, and you need to commit to do it. And so in a way, I don't actually agree with a lot of the part-time training. That can be open for debate, but because I do feel that as a surgeon and as orthopedic surgeons, we need to be committed, and when there is an emergency, we can be tough and we can do it. So this is something that I do feel strongly about. And so so I mean, we have maternity leave for ones that who've got pregnant, but then they come back. So the female surgeons are quite tough in Hong Kong, especially. So so I'm not saying that they will give them an easy job. They easy path. They have a part-time. They should have other people to help. They need to toughen. They need to spend the hours. And and with that, then we are open to have more different genders.
Thank you, Margaret. Anyhow, we have a lot of presentations remaining in our session. Just to save time, allow me to welcome Professor Dr. Nashat Naam. It's a great pleasure for me, Dr. Nashat, to welcome you in this year conference. Dr. Nashat is an eminent orthopedic surgeon, Egyptian. I'm so proud of that. And he's the past president of the American Association for Hand Surgery. Dr. Nashat, welcome again in our conference.
Thank you.
It's a great pleasure for us to have you.
Thank you so much. I really appreciate the fantastic opportunity to be here, and I really appreciate Professor Abdul Hakim to put this topic on the horizon, because really it's a very important topic. And although I'm coming from the US, still the challenges that face all the female orthopedic surgeons in Egypt or Hong Kong or Korea or Mozambique, the same that also challenged the female orthopedic surgeons in the US. Yes, I'm delighted to be back in my beautiful country, the cradle of civilization. I would like to congratulate the Egyptian Orthopedic Association for its 77th meeting, and a special congratulations to my friend and my mentor, Professor Abdul Hakim Abdullah. The mentors don't have to be older than you. They can be younger, much younger, but still you learn a lot, and I've learned a lot from Professor Abdul Hakim. My relationship with EOA started with this talking about acknowledging your mentors. One of the major mentors that affected my personal and professional life is Professor Hassan al-Zahir bin Adir Saha. And also I have another mentor. They are difference in age, but those two mentors, I cannot be happier than that. And I was delighted that I received Professor Abdul Hakim in Effingham in the US, and he honored us with his presence. And surprisingly, surprisingly, he was so popular with females. He's very handsome, as you can really see. And when they gave him this shirt, they didn't have the shirt and they stamped it. No, they put the shirt on him, and then the girls came with their hands and started. And I don't want to make a comment about the last one. And then Abdul Hakim became the first president of the Egyptian Society for Surgery of the Hand and Microsurgery, and he did an outstanding job, and now it's in our 19th year, and he mentored lots of people, especially the new generation, and he welcomed some of the most eminent hand surgeons in the world, and I really appreciate that very much. Just recently, he presented Egypt in the Academy of Orthopedic Surgery in the US, being the president of the EOA, and he gave a fantastic speech because the Egyptian Society was the guest nation.
I'm proud to stand here representing the Egyptian Orthopedic.
So we're talking about empowering women. What's the US experience? The US experience was not really smooth or easy, and started at the beginning in the early barriers. Like before 1900, women were not allowed to really do surgery or excluded completely from surgery. And then gradually, they started to have some more introduction. Dr. Ruth Jackson became the first female orthopedic surgeon in the U.S., and she was admitted to the AOS in 1937. After that, the new leaders came in the sort of mid-century, and then gradually in the 70s, there was a women's rights movement, and that allowed more female physicians and more female orthopedic surgeons. And the Ruth Jackson Society started in 1983. Now, in this millennium, things are starting to improve. In 2000, there were only 4% of all the orthopedic surgeons in the US were women. Now, there are 8%, but at least 18% of the residents are female, and that's good. That means the new generation is coming, and the number of orthopedic surgeons, females, is improving. And then this really a landmark. Dr. Christy Weber was the first female president of the American Academy of Orthopedic Surgery in 2019. And in her presidential speech, she said the future of orthopedics depends on diversity in thought, skill, and vision, and that will be by the female orthopedic surgeons. But still, there are lots of challenges ahead. Still, only 8% of practicing orthopedic surgeons are female. We need more, but there's still the same bias and same work-life challenges that we heard the previous speaker eloquently speak that. And also, you need some mentors. The mentorship is extremely important in creating a new generation of orthopedic surgeon females. When I became president of the American Association for Hand Surgery, I wanted really to empower more females. I had the same idea like Dr. Abdul Hakim. So I asked Julie Adams, one of the most distinguished female orthopedic surgeons in the U.S., to be my program chair, and she did an outstanding job. And when I became the head of the nominating committee, all the new positions were filled with females. If we really don't make a special effort to include and encourage our female colleagues, it's not going to happen. We as males, exactly what Dr. Abdul Hakim said, we as males, we have to really encourage and support our female colleagues. And Julie wrote that article, Where Are the Women in Orthopedic Surgery in the US? And she found that most of them are in the Midwest, and most of them are in these specialties, hand, the great majority of them, even in general orthopedics, pediatrics, and sports medicine. So the concept that physically you have to be with big muscle, I'm really not big muscle at all, but I mean really that concept is no longer valid, because really some of the female orthopedic surgeons, like Margaret is very tiny, but she's very powerful. So really, that concept, I think this issue, we really should really go beyond that completely. She found also in that study that most of the female physicians were in academic practice or hospital employed. So why do female orthopedic surgeons go to orthopedics? Primarily, the most common reason is enjoyment of manual tasks. I put this is my partner, Lisa Sasso. She is a female orthopedic surgeon. She is tiny. She's like 5'2", and she weighs not more than maybe 90 kilograms. But she's a very wonderful orthopedic surgeon. And the other option, the professional satisfaction and the intellectual stimulation, these are some of the factors that prompt female physicians to go into orthopedic surgery. So what are the obstacles that prevents female physicians from going to orthopedic surgery? The same concept, the perceived inability to have a good work-life balance. Lisa, that I showed you her picture, has 4 children, and she is a successful orthopedic surgeon as well. And also the perception that 2 muscular activities are really needed. Still, these are some of the obstacles that really prevent females from going into orthopedic surgery. And the lack of strong mentorship, that's really important, very critical. These are my partners, Lisa and Patrick. We don't take ourselves very seriously, as you can tell. And in conclusion, empowering women in orthopedic surgery is critical. As Christy Weber, the first female president, said, diversity in orthopedics is not just a moral issue, it is essential for excellence. And even in the US, there's still significant difference in the number of orthopedic surgeons, females compared to males. We can gain important lessons from other countries as well. And at the same time, it's critical to create a welcoming and safe environment for our colleagues. And I was so delighted to hear that in Algeria, you have a great number of female orthopedic surgeons. I hope that next time when we come here to our meeting, we can see more female orthopedic surgeons. Again, thank you so much for this opportunity. I really appreciate it. Thank you.
Thank you, Professor Nasser. Open for discussion.
I just remember something we talked about like 20 years ago. I was with him in the state. He told me that you have to work in positive discrimination. This was a unique term for me at that time. But when I thought about, sometimes you have to push in the direction of supporting others.
It's extremely important.
Thank you, Professor Nasser.
Thank you, sir.
Now
Thank
we
you.
move for next speaker from Asyut University, one of the eminent professor surgery, especially pediatric. She is going, Dr. Nariman, she is going to speak about 23 years and counting female orthopedic surgeon experience. Dr. Nariman.
Bismillah ar-Rahman ar-Rahim. Thank you very much for inviting me here. Thank you, Professor Abdul Hakim, for thinking of this idea and having the intention to promote female orthopedic surgeons in Egypt. I would like to introduce myself. My name is Nariman Abou-Ayoun. I am an associate professor of orthopedic and trauma surgery at Asyut University. I am a consultant of pediatric orthopedic surgery. I've been in the field, as you can see, for 23 years now, so I have a long time to look back at and learn from so many lessons I've had along the way. Let me start by giving you what I think orthopedic surgery is all about. It is just another job with special circumstances. It comes with 24-hour shifts. It comes with the need to study for board exams, career promoting certificates, and a lifelong improvement aspiration. You need to do research if you have the intention to add to the body of knowledge in the world of orthopedics. You need to have successful, I'm not saying perfect or excellent, but successful clinical and surgical performance with excellent bonding skills to promote yourself as a surgeon in the eyes of your colleagues and of your patients, especially if you are a pediatric orthopedic surgeon. So then bonding to the patient and to the family is crucial to your job. I started my career in 2002 in Asyut University Hospital. I received my master's degree in 2005. I traveled immediately to Germany, Hamburg, Germany, on a clinical fellowship for 2 years, funded by the DAAD, or the German Academic Exchange Office. I came back in 2009, went for an observership at the hospital for sick children in Toronto. I passed the fellowship examination of European Board of Orthopedic Surgeons in 2011. I received my doctorate or medical doctorate degree in Asyut in 2012. I traveled again to the US as a research fellow at the Children's Hospital of Philadelphia, and that was for a year and a half. And I got back in 2015 and received, one of my publications received the AO Spine Middle East Young Researcher Award, followed by the Oribi Zamuju Award granted by the CCOT for one of my publications in 2016. So it's been a long way of aspiration and determination. I've been attending international conferences ever since I was a very young female orthopedic surgeon. It went on and on and on. Along the way, I'm happy to have met so many good mentors along the way, especially in addition to those who I have at Asyut University, but of course I met other people as well, and it turns out to be that females on both ends of a continent could have similar dress, taste. That's a colleague from Nigeria. Even when I was 7 months pregnant, I traveled to Oman to attend the CCOT, and there I met Professor Sam Sharif, of course, my greatest mentor. Professor Dormans, whom I worked with at CHOP, and I really cherished the opportunity to have met so many inspiring female orthopedic surgeons from the Arab world. These are Drs. Ala Abu Hajla in the middle from Jordan, and this is Dr. Dalal Boubshit from Saudi Arabia. Now, research has been taking a good part of my time. I'm not great, but I'm not so bad. These are my the papers, the publications that I've already published. Some of them are the international, some of them are the good local journals. And of course, the beloved Egyptian Orthopedic Journal is one of those very important publications. So women in orthopedic surgery, in my opinion, have started to have a voice. Now that the women in orthopedics worldwide, the WOW community and the IOTA community have been trying to, cover the facts and give an estimation of how many women we have in orthopedics. So, as it turns out to be, it's still not obsolete that women are not equal to men in orthopedic surgery. Many places in the world, even the best places in the world, have maximally 25% female orthopedic surgeons, and I think that's exceptional. It's not like that where we are. It's not like that in most of the world. I've received this table from my dear colleague Dalal Boufshit, and it gives a very, very insightful indication that women in the Arab world are really, really not motivated enough to share or participate as orthopedic surgeons. There's a very positive part in Saudi Arabia where they have been able to move and leap forward, promoting females in the field of orthopedic surgery at a number of 145. And I think this is a bit old because I know in Egypt we are now over 14. So it might be even more in Saudi Arabia than this. Let me, please, Professor Adel, let me give you what I've seen, okay? I know you are progressive, but not everyone is progressive. So let me give you what I've seen and what I've been through. Men think, first of all, and you've witnessed that right now, we have to go to the gym to be orthopedic surgeons. Well, we know that doesn't happen. They don't go to the gym. They just tell you that when you're a young, aspiring female, house officer, that you want to go to the field of orthopedic surgery. So they say that to you to discourage you. Women would panic at the sight of blood and would not be able to open up a patient, make timely, wise decisions during surgery, and get to the finish line having done what she needed to do. Women will take leaves 4 months if they're having a baby and have to attend to their families, a huge disruption to the workflow and timetables. What women see is the other way around. We, as women, are traditionally, and have been traditionally, trusted and relied upon, and we were thought of as strong enough to perform heavy household tasks, and I mean heavy, physically heavy household tasks without help. So to us, women, orthopedic surgery is just another task. The sight of blood is the least of our worries. The challenge is in the pressure we put on ourselves to make our work flawless, which is impossible. But we put this pressure on ourselves to avoid gender-based discrimination. Men leave to military service for 1 to 3 years, and it's never regarded as a disruption to the smooth workflow and timetables. Some countries allow men or fathers to take a year off for childcare. Taking time off for your family is not a crime, be that a man or a woman. So, some people just take the liberty to openly discourage a female orthopedic surgeon, even before she starts her career or even during her career. They feel that can go nice and easy and that doesn't hurt anyone, but it does. It's not major, but it's not nice to hear that every day. If my son breaks an arm, I will never bring him to a lady surgeon. We all know women can't take night shifts. It's very clear a woman would never be a good surgeon. We've all met people in our work environment that are not skilled enough. Men in that corner pass unnoticed or sometimes receive sympathy. Oh, he's not so good. But women, she can't be a surgeon. Some would limit her time in the OR if they have the authority to do that because they are sure her male colleagues are more entitled. Some go a couple of steps further and attempt to sabotage the work of their female colleagues. Some do even worse. The real challenge, in my opinion, not all that is just talk and you can get over it. But the real challenge, there is a true challenge. It's mostly, as in any other job a woman would take seriously, family support is needed. Examples of successful women supported by their husbands and families are very numerous in all fields, not only in the medical field. Working full-time does get in the way of having a classic rich family life, and that applies for men as well. There are men who've been working all their lives and know very little about their children and their families, and they regret that later on when the time is already gone. A mother cannot be separated from her children. She will have to plan meticulously, and when the time comes, she must be there. So, timing. Do you get children when you're young and starting your career and let that interrupt everything you're doing?
I'm just joking. I said, well, let Allah decide.
Exactly, but still, you could plan. You have a say. But you're not alone in this. So you even choose to do that early in your career, which, puts difficulties to, okay, I'll be done soon. Or you decide to delay that and have that mid-career when you've already established and are standing on solid ground. During pregnancies, you have health-related issues. You're exposed to radiation sometimes, especially if an accident happens and unintended radiation has happened, and you live with the guilt until a healthy baby is born. After the baby is born, it turns out orthopedic surgery was easy. The real thing, in my opinion, bone surgery is actually delicate surgery. You don't really need all those muscles. You're expected, like any surgeon, to preserve all tissue integrity, do the least harm to the apparently tough but living bone tissue. Work hard and smart. In real life, patients trust the better physician, man or woman. That goes for surgeons as well. If some are prejudiced against us as orthopedic surgeons, and a few are determined to stop our careers, the majority is just waiting to see. Well, prove yourself. If you need to work twice as hard to prove yourself, be it. Welcome the challenge. Prejudice and bias are primitive human nature. If not gender-based, it will be color-based, it will be religion-based, it is going to be socioeconomic status-based. So don't cry about it. It has never stopped anyone from getting where they want to go. My view of the matter is, it is the right of every woman, working woman, to choose her career and to be a mother when she thinks is appropriate. It is hard for any working woman to battle on all fields. Some female orthopedic surgeons do fall off the grid, and it's well known, overwhelmed by the difficulties, and they choose their kids over their future as surgeons, but it's okay. They do that wholeheartedly and with love. The farther we get through our careers, hopefully with success, the easier it is to achieve balance. Cheer up, ladies. You will get the support you deserve from so many people around you, and this is an example. My life has been an example. I've received support from all my professors in Asyut University. I've received support from professors that whom I've met in international meetings, like Professor Gamal Hosni, Professor Baha Qurna, Professor Adil Adawi. I've received enormous support, or I wouldn't be standing here this time. Once they know you are passionate, you are skilled, and you are devoted. Everyone should be allowed to have resting stops along the way, be it for academic studies, family care, traveling the world on a self-search journey. That's okay. Take a short stop. You will bounce back stronger than before. We, as a civilized and educated community, should allow our members to give their best, blossom the way they choose. We should lift up the weak, because no one stays strong all the time. And this is the day I was promoted to associate professor. I'm the first associate professor female orthopedic surgeon in all Egypt. And I'm the third orthopedic surgeon in all Egypt, too. I'm proud about that. Thank you, Professor Adel. Thank you, Professor Behet. Thank you very much.
Thank you, Nariman, very much for your excellent presentation, as usual. I'm so proud with Nariman, by the way. I had the honor to upgrade her to the degree of associate professor.
The honor is all mine. Thank you.
And we are waiting you to be a full professor, inshallah. But I'm sure that you have overcome, Nariman. It was a great challenge for you working as a female orthopedic surgeon in Upper Egypt. Yes.
Yes.
Welcome to your daughter.
Oh, thank you.
One of the most important challenges that I know well that she has overcome it is how to convince the community in Upper Egypt to be a successful female orthopedic surgeon. This is the most important challenge, because for the inherited beliefs that orthopedic surgery is only suitable for males, not for females. I think you have faced a lot of difficulties.
Can I answer that?
Yes.
Well, of course. As a junior orthopedic resident, It was very common that I would receive the question from the patient or the patient's family, are you going to do the surgery? It's like, that's, first year.
In spite of that, in that community, they go directly to female gynecologists, for example.
Oh, yes. And to female orthopedic surgeons. That ended a year or two later, when it was clear that I know what I'm doing, that I'm taking good care of my patients. Patients don't care if the doctor is a man or a woman. They go for the better one. They want their own good. So I did not have problems with patients after the first year of my residency. Thank you, sir.
Thank you. Now we shift for next speaker, Dr. Samah Bakri. She is going to speak about overview and the history of orthopedic in ancient time.
Yes.
With the thinking orthopedic surgery is the type of culture near, open culture near and osteoporosis.
Overview of the history of orthopedic surgery in the ancient times. I'm Samah Bakri. Okay, thank you. The objective is to give a glimpse, to connect the past and appreciate the present and the future. Connect humanities with natural sciences. Ancient Egypt. The Edwin Smith Papyri. It has 48 cases. 10 of them are orthopedic ones. Immobilization was the suggested treatment. Ipwi. Who is Ipwi? He's a sculptor. He's not a doctor. We owe him that. This painting is our sign. This wall drawing is a catafalque, which is بالعربي دناش. It displays the occupational hazard. And occupational hazards, there is an ophthalmology also. Hisesht. She is the ancient Egyptian doctor from the 4th dynasty. She was lady overseer of physicians. They used the Hippocratic corpus in ancient Alexandria as the main reference. For anyone who's looking for what Hippocrates wrote on orthopedics, you will find it in the Loeb Classical Library edition, on fractures, on joints, and instruments of reductions. And these are samples of his techniques. These illustrations are from a manuscript belongs to the 10th century AD. That's how he used hip reduction. And that's how he performed spine injuries reduction. There are some archaeological samples of complications in orthopedics. It displays the humeral head, the malrotation, and the gross malrotation in the 3rd sample. There is also a malunited fracture. There is an examples. These are not from Egypt, these from Ephesus, and these were gladiators. And this is a sample of cavities in the spine. They assumed it was TB, and then by DNA it proved to be just Procella. Thank you.
Thank you, Dr. Maro. It is very nice presentation about old ladies. Now we'll shift for our next speaker will be Dr. Marwa Ali. She is going to speak about management of pathological proximal femoral fracture through an aneurysmal bone cyst in pediatric athlete. She is from Swiss Canal University. Welcome.
Welcome. Good morning. I am Marwa Ali Mahdi, Assistant Literature of Orthopedic Surgery and Traumatology, Swiss Canal University. I am specialist in pediatric orthopedic. First of all, I should thank Dr. Abdel Hakim for this opportunity. It's an honor to stand after Dr. Nariman, my mentor, and my role model on the same stage. And I should thank every staff member of the Faculty of Medicine, South Canal University. The story begins with a 9-year-old footballer. He fell on the ground during his training and he had a severe hip pain, so he couldn't stand up again. He was brought to the nearest hospital. X-ray was done and he broke his femur bone. A shock. How a 9-year-old fit and healthy boy just fell from his own height to the ground and broke his femur bone by just a trivial trauma? The answer is aneurysmal bone cyst. How to suspect aneurysmal bone cyst? Fracture with a trivial trauma, recurrent pain in a patient younger than 20-year-old. To diagnose aneurysmal bone cyst, first we do X-rays. X-rays show expansile, eccentric, lytic, bone lesion with bony septa. Cortex thinning out, metaphyseal. The location is around the knee, proximal femur or proximal humerus, and also in the posterior element of the spine. CT show cortex thinning out, also used to see the size of the cyst, the proximity to the physis, and to confirm the absence of mineralized matrix to rule out other lesions. MRI show fluid level and to detect any soft tissue invasion which raise the suspicion to other lesions. How to manage aneurysmal bone cyst? We either manage it by observation and regular follow-up or by surgical treatment. The indications for observation and follow-up is asymptomatic patient who is accidentally discovered and pathological fracture that doesn't require fixation. The indications for surgical technique or surgical fixation are symptomatic patient with pain and swelling, or asymptomatic patient who show increasing in the size in the follow-up, or pathological fracture that require fixation. Differential diagnosis of a bone cyst is either aneurysmal bone cyst, unicameral bone cyst, and telangiectatic osteosarcoma, which is very similar in presentation to the aneurysmal bone cyst. We should differentiate between these three. The aneurysmal bone cyst and the unicameral. The aneurysmal is eccentric and the simple or unicameral is centric. Also the bony septa. There are bony septa in the aneurysmal bone cyst, but the simple show a single cavity. Telangiectatic osteosarcoma have the same features as aneurysmal bone cyst. We can differentiate it by MRI to show the soft tissue invasion, clinically by the progression, rapid progression of the disease and the severe pain, and also by when we suspect telangiectatic osteosarcoma, please do CT guided biopsy before fixation. Back to our case. The history of the patient show trivial trauma, 9-year-old healthy and fit, normal milestone, no syndromes, and no family history. Examination show 9-year-old, featureless, normal growth, average weight and height, with externally rotated left lower limb. The other limbs were normal, intact skin, closed injury, and intact distal neurovascular. Investigation. X-ray show eccentric, expansile, lytic lesion in the proximal femur with pathological fracture. CT show thinning out of the cortex, show the comminution of the fracture, and show also the bony septa, which suggestive for aneurysmal bone cyst. After discussing the case, decision was made for curettage and pathology, filling the defect by autogenous fibular bone graft to maintain the length, fixation reduction, fracture reduction, and fixation by fixed angle pediatric locked hip plate. Intraoperatively, the patient was under general anesthesia, supine position, lateral approach to the proximal femur, extensive curettage by a curette was done and sent to pathology. Reduction and fixation after harvesting a long fibular graft for maintaining the length. Only 2 proximal screws were used due to the lack of bone stock. We augment the fixation by hip spica due to the deficiency of the proximal fixation, only 2 screws, secondary to the lack of the proximal bone stock. In the 2 weeks follow-up, suture removed, and we reassure the family that the results of the pathology test show benign aneurysmal bone cyst. 6 weeks follow-up show consolidation and fracture union, hip spica was removed, and the patient allowed to weight pair as tolerated. 2 weeks after removal of the cast, the vein has good range of motion. 4 months follow-up show complete healing and consolidation of the fracture. Fibular graft was taken, good, and the patient can wake pair and walk painlessly and have no limb length discrepancy. Take home message, suspect then confirm. In children with recurrent persistent pain, suspect the underlying lesion with X-ray and confirm with MRI the fluid level. CT-guided biopsy is mandatory to differentiate from telangiectatic osteosarcoma when suspected. Fix the fracture and eradicate the disease, a dual strategy of stable internal fixation and extended curettage is non-negotiable for success in pathological fracture in weight-bearing bones. Excellent outcomes are achievable. With meticulous technique, even complex cases in children can achieve full bone union and functional restoration. Thank you.
Thank you, Marwa. Shukran. Any question for Dr. Marwa? Yes, you have a question. Dr. Marwa, you still have one question. Yes.
Okay. Of course, I think about telangiectatic osteosarcoma. I excluded it with the patient has no complaint of pain, no soft tissue mass. Also, in the hospital where I work, I didn't have the facility for CT-guided biopsy. So I take consent from the patient, I take the risk, and if I يعني لو كنت في العملية لقيت حاجة شكلها malignant كنت هاخد open biopsy واقفل وبعد البيوبسي نفتح تاني بس ما كانش عندي
Your patient is 9 years old. 9 years old. Yes, if you are going to differentiate in this case, you are going to differentiate mainly between ABC and simple bone cyst, mainly regarding this age and the history that she said. Yes. But if you are suspecting telangiectatic osteosarcoma, the only differential is to do CT-guided biopsy. But it is.
Any other question?
Thank you, Margaret. You told us that you have fixed your case by fixed angle pediatric. This is not a fixed angle.
This is not fixed angle. This is an
This is locked proximal femoral plate, not a fixed angle pediatric plate. Yeah. Yes. Next.
Now shift for next speaker, Dr. Nurhan Mahmoud. She is going to speak about sport injury in female footballers.
I am Dr. Nurhan Mahmoud, orthopedic surgery resident at Sheikh Zayed Al Nahyan Hospital. Doctor of NB football, women football teams. I want to thank Dr. Abdel Hakim for this chance. I'm sorry. And Dr. Nariman Abrayun, our mentor for all female orthopedics. في حاجة تانية عايزة أقولها برضو إن أنا كان في بعض الناس برضو يعني my mentors يعني كانوا supportive مش كله يعني السويد الدنيا برضو كانت فيها شوية أمل يعني. Introduction. Lower limb injuries represent 70% of all injuries. Non-contact injuries, a significant number of injuries, especially ACL injuries, occur from non-contact mechanisms. Training versus games. Large portion of injuries occurs during technical, tactical, or physical training sessions. Hormonal fluctuations. There is ongoing research into how hormonal changes during the menstrual cycle might affect injury risk, particularly for ACL injuries. Anatomical and biomechanical factors. Intrinsic factors like anatomy and biomechanics, along extrinsic factors like training load and footwear influence risk injury. Most common female footballer injuries: lower extremity injury, Ankle sprain is the most common injury, especially lateral sprain, knee injury, ACL tear, meniscal tear, and bursitis, quadriceps and hamstring and adductor strains, head injuries, concussions, fractures, traumatic fractures or stress fractures, mostly occurs in metatarsals. Overuse injuries include Achilles tendonitis, patellar tendonitis, and shin splints. Ankle sprain, the most common sport injury in female football players. It causes a sudden change in direction and tackling and awkward landing after jumping, twisting injuries, ankle instability. Treatment of ankle sprain, immediate treatment, RICE protocol, wrist ice compression and elevation, ankle gel support. Long-term management and prevention includes physiotherapy and rehabilitation, tapping or bracing to prevent recurrence, proper footwear, surgery in severe cases of ankle instability, and failed conservative treatment. Ankle sprain recovery time, grade 1, slight ligament overstretching, recovery from 2 to 4 weeks. Grade 2, partial ligament tear, recovery from 6 to 8 weeks. Grade 3, severe complete ligament tear, recovery from 3 to 6 months, often requires surgery. ACL injuries are the most common knee injuries in professional athletes. Incidence in females is 8 times in males due to multiple factors. Anatomical factors, smaller femoral notch impinges on ACL, and this increases the risk of ACL injury. And also it has been shown that females with ACL injuries have high tibial slope more than male patients with ACL injury. And also all patients with ACL injuries have high tibial slope even more than any normal persons. Hormonal factors, fibroblasts located in ACL have estrogen receptor, and estrogen directly impacts the laxity of ligament and overall limb alignment. So variation in level of estrogen during menstrual cycle can increase risk of ACL. Biomechanical factors, females increase the hip flexion during landing and increase contraction of quadriceps muscle during landing than males, which increases the risk of injury. Recovery time after ACL injuries, ankle sprain, ACL sprain, non-surgical treatment, grade 1, 2 to 6 weeks, grade 2, 6 to 12 weeks, post-ACL reconstruction from 6 to 9 months. Clinical outcomes after ACL reconstruction in female athletes. It has been shown that female athletes have 2.26 times increased risk of graft rupture following ACL reconstruction using hamstring autograft compared with bone patellar tendon bone autograft. A smaller diameter of hamstring autograft in female athletes than males increases the risk of ACL reconstruction failure, so some authors have suggested that hamstring graft should be prepared to ensure that their diameter is greater than 8 millimeter. Hamstring strain, grade 1, tearing of a few fibers of full muscle fibers, swelling, discomfort, minimal loss of stretch. Grade 2, more severe partial tear without complete disruption of musculotendinous unit, clear loss of strength with more discomfort, complete rupture of the musculotendinous units, grade 3, total lack of muscle functions, and commonly with massive hematoma. Treatment of hamstring strain, immediate treatment or RICE protocol, physiotherapy and rehabilitation programs, surgical treatment, complete tear of tendon avulsions. Recovery time for hamstring strain, grade 1, mild, few days to 3 weeks, grade 2 from 4 to 8 weeks, grade 3 months or maybe longer if surgery is required. Concussions, female footballers have higher risk of concussions than males due to weaker neck muscles and hormonal fluctuation leading to greater head motions and potential data vulnerability, and also females showed longer recovery time than males. Recovery Gradual return to play should be done according to guidelines after the player becomes symptomatic free for at least 24 hours. Thank you.
Thank you very much for this presentation. Now we shift to our next speaker, Dr. Marwa Rafat. She's going to speak about neglected volar marginal rim fracture of the distal radius. Case presentation.
Good morning. I'd like first to start by thanking Professor Abdul Hakim for being a great mentor ومستحملني كل ده. So today I'm presenting a case of neglected volar rim distal radius fracture. I'm Marwa Rafat. I'm a lecturer of orthopedic surgery in Alexandria University. So just to start off with the case. So this is a 23-year-old male who fell on his outstretched left hand 2.5 months ago, and he presented to me 2.5 months following trauma. He said that he was previously managed by a dorsal slab followed by a cast, but unfortunately I didn't have any access to his original x-rays. He's neurologically intact. This is his plain x-ray, the AP and lateral view, and clearly we have a volar marginal rim fracture of the distal radius with ulnar and volar subluxation of the corpus. And here with the CT, it becomes more evident that we have a subluxation of the neonate. So if we go back to the literature, we have a classification which is basically a descriptive classification for this volar rim fracture described by Gregory, Bain, and McLean, and this was considered to be a type 1. The issue with the volar marginal rim of the distal radius, it is a very important part because it has a load-bearing function, as this thick volar trabecular column spans from the metaphysis of the radius to the cortical subchondral bone to allow for load transfer, and it contributes to the stability of the distal radius and the corpus because of the attachment of the volar radioulnar ligaments, since that they arise distal to the watershed area from this tiny volar marginal rim. The trauma usually occurs when the wrist is in extension, so the ligaments will be tight to create a compressive force, and then when an axial force is applied, they impact the neonate against this volar ulnar corner. With the intact ligament, they lead to the volar subluxation of the corpus. Fixation challenges occur because we can't just fix it with the typical standard anatomical distal radius plate, and while the post-operative x-ray could look fine, if we look back maybe in a week or maybe less than a week, we can have the subluxation because this distal marginal rim is not supported by our standard anatomical plates because they are all placed proximal to the watershed area. So we can just put the plate a bit higher, but this carries the risk of tendon rupture. So if we go with this option, we should remove the plate early. We can go for fancier options by using the spring plates, which are not available here in Egypt, or the volar buttress pin, or a hook plate extension to the anatomical distal radius plate. We can just fix the ligaments using anchors or using mini screws and add a neutralizing bridging plate if we need to. So looking back to our case, I went with the volar ulnar approach because you won't have good access to this fragment with the standard modified Henry approach. And in this approach, we go between the FCU, its ulnar, and the flexor tendon and the medial nerve radial, and this will give you a heads-on visualization of this fragment. First, I started by reducing the neonate by placing a radio neonate wire in order to fix the neonate from the volar subluxation, and then inserting the guide wire for the insertion of the mini screw. I wanted to place a much smaller screw or a low-profile screw, but this is the only one that was available with us in this case. And then I wasn't much sure of its fixation, so I added a bridging plate just for protection. These are the immediate post-operative x-rays. and this is the 4-month follow-up. And I did a CT just to confirm the union. After 4 months, I removed both the plate and the screw because the patient started to complain of some median nerve symptoms, but once the screw was removed, he was fine. And this is the 6-month follow-up and the 18-month follow-up, which show no subluxation of the leonate or the carpus. And I did the CT just to make sure, but I didn't think I needed the CT. And this is his range of motion after 18 months. So in conclusion, volar marginal vein fractures are challenging injuries. They are associated with a high rate of fixation failure and other carpal injuries. So selection of surgical approach and fixation technique is critical. If primary fixation is any in doubt, a bridging plate should be added to neutralize forces and allow healing. Thank you.
Thank you, Dr. Maro. Just why don't you use external fixator instead of a blade, and you need to remove it by another surgery?
We usually do not use in our practice we stay away from wrist external fixator because of the complications. We found that bridging plate is a very good alternative and it has much lower risk of complications. Even if we kept it in 4 months, the patient can restore the range of motion as long as it's put in correctly. Because if it's not put in correctly, it can cause extensor tendon injury. So it has much lesser complication than the wrist external fixator.
You can use 2 millimeter T-plates and just you put it and contour it and buttress the fragments.
Yeah.
Just 2 screws.
This was the original plan, but احنا كنا في الجامعة و يعني we had some issues with the implant. The original plan was placing this, but I opened up العلبة لقيت we have only 2.7 screws, so I kind of improvised.
The concept of treating just fracture is just
to buttress the rim. Yes. Okay, thank you.
Okay. Now we shift to the last speaker in this session, Dr. Rahab, resident at Orthopedic at Asyut University. She is going to speak about an orthopedic resident at Asyut University.
Assalamu alaikum. Thanks for all the stuff. And many thanks for Dr. Nariman and Dr. Ali Firgani. This is presentation about an orthopedic resident at Asyut University was he supports me so much. He supports me so much. This presentation about an orthopedic resident in Asyut University Hospital with assortment of cases. I'm 28, 9 years old. I'm married and have a baby girl. I run the orthopedic department in April 2022. I'm only the orthopedic female resident in Asyut, but not only female. My great professor, Dr. Nariman, preceded me. I'm registrating for master thesis in spine unit about the surgical treatment of thoracolumbar spinal metastasis. Why orthopedics? I'm interested in trauma and fractures and spine surgery. These are to make immediately and life-changing of patient and rapid recovery, and I love watching individuals regain function and return to daily life quickly. I love uniqueness and differences, and in our community, or in Asyut special, المحجبات المنتقبات they need special female to examine him, and I love this so much. I'm broad and beginning part of an Austria University hospitals is a big center for trauma and high surgical volume. For example, the total admission in Austria University Hospital in 2024, 15,514 trauma present 77%. challenges طبعا كلنا واجهنا تحديات يعني بس كلها طبعا الجندر النيرس الدكتورز ستاف patients all community surprise in female in our field or department difficulties for me for private room for women in operative room, in trauma inpatient, in everything in department for private room. Heavy workload and physical expectation, need for equal mentorship and opportunities, patient and doctor and everybody in our society. Not usual to have a female doctor. We encourage a female and empowering women in orthopedic surgery. We actively involved in emergency coverage and operative management and post-operative follow-up. This is some cases, clinical cases I did in my department. This is a male patient present with fracture L1 and short segment done. 60 years old female with genovirus, high tibial osteotomy done. This is with genovirus, pre, long film pre and post, and this is a follow-up after 6 months with full range of motion. Uh, 23 years old male present with fracture proximal left humerus, phallus done. This is as a 6 months follow-up. This is a supracondylar intercondylar left femur with anatomical distal femoral lock done. 90 years old female presented with fracture neck femur, hemiarthroplasty done. This operation take 25 years old to 25 minutes with complication of cement syndrome. This is a follow-up after 4 months follow-up. This is with multiple fracture of proximal phalanx, little and ring and head radius. And head fifth metacarpal with Herbert screw with full range of motion. Uh, 14 years old male with comminuted fracture distal radius with bridging plate and Q-wires done. This is after Q-wires removal. This is a follow-up after removal of bridging plate, 100 days, and full range of motion. This is the distal shaft of right humerus is posterior plating done. This is a mid-shaft fracture of nail tibia, sorry. And this is a follow-up after 6 months. This is a mid-shaft right clavicle. Orif done. My message: power is not given. زي ما كل الناس معتقدة إن إحنا فيميل وإحنا دي هتدخل تشد دي، لا كده يعني. Power is not given. Strength is skills and dedication and perception. Beginning the only female resident is very hard, but it opens door for others. Despite of more limitations, challenges, and difficulties, I love orthopedic so much, and I belong in this specialty. Conclusion: women can lead in orthopedic surgery women can excel in trauma and management and operative. Women can change surgical culture. Women, although usual strong. This is a lecture with my great professor Dr. Sam Sharif and Dr. Muhammad Mustafa Ud. And this lecture when I won the best model for fixation of midshift or femoral forearm fractures in basic AO course.
It was positive discrimination.
This lecture for AO in hospitals in Aswat University Hospital. With many thanks for Dr. Osama Farouk and Dr. Mahel Hassan, Dr. Hussam Abid, Dr. Mahmoud Badran. This is why with my juniors. I thank my husband and baby. وبرضه احنا بنعرف نطبخ وبنعمل أكلات حلوة. We can do both. Thanks.
Thank you, Dr. Rahab. I think we are running out of time and we have to.
Dr. Rahimiyya from Algeria. Just give us like 1 minute.
Okay. مرحبا.
1 minute talk عن experience, Algerian experience.
Thank you.
تفضل.
I think I'll stand up. Hello, everyone. Margaret, Madame Neriman. I don't know if I should be proud of you. Sorry for your experience. I'm really amazed. Yes. 10th orthopedic surgeon, 3rd orthopedic surgeon for such a big population, such a big country. I'm amazed. And about the Yoda statistics, you need to change it. You need to update it. Because only in my unit we are 21 women, not 12 for sure. Actually, I did my med school and my specialty in Ukraine. And when I was in the first 6 years of studying in summer, instead of going to the beach, I used to go to the Algerian hospitals for practice. And it was over there that I fell in love with orthopedics. So I remember when I started my PG in Ukraine, no, it was not like this. I was like 10 kgs less, short, curly hair and everything. And I came to the head of department and he's like, why orthopedics? You're not strong enough. I said, I'm smarter. And also in Algeria, for sure I will work. And this is how I got into orthopedics in Ukraine. I was the only woman. When I went back in Algeria, بالنسبة لمعادلتي, so I was put back in 3rd course residency. I remember first week, I was on duty with 3 other girls also, and we had a hip dislocation. So my senior resident was like, Rahimiyya, just take an inter and go fix it. And I'm like, I'm a princess, I don't do that. It's heavy. And she was like, never say that, just follow me. You don't need to work hard, work smart. And it's very evident, I saw, I hear, and I think I feel the problems that you face with men. Believe me, in Algeria we don't have that, like men, women, you're just orthopedic surgeon. We have professional problems with administrations, with screws, with I don't know, with less of food, but we don't have room, men, women, you do, I don't. I'm only 35 years old. My husband is also an orthopedic surgeon. He's my first enemy, actually. He's a bully. He's a bully, not because I'm a woman, just because he keeps on seeing me, the resident he met 6 years ago. That's it. Like, but we never have that. We never feel that. I think that orthopedic departments in Algeria are more perfumes, hormones, and everything than men and women. We're dominating everything. And seeing that you don't have much, especially, I'm sorry, for an Arab country, in Algeria, like you said earlier, when you come like, هذه طبيبتي. No, in Algeria it's opposite. I don't want man, I want a woman. مانيش حابة راجل يكشف عليا. إذا الزوج إجا مع زوجته من فضلك ممكن مرة هي اللي تشوف زوجتي، ممكن مرة هي اللي تعمل عملية على زوجتي، ممكن مرة هي اللي تشوف بنتي مثلا. We are really recommended, really. So I hope, as I always say, you are the first, so be the change. I really admire that. As who is the resident? She said, you may open the doors. And then, let's say through the countries, we're always here to help and to give support or to give examples. And I don't know how we can help, but I wish the best. I wish the best. Thank you.
Thank you, and now we have to close this session because we overcome.
Just announcement for our decision in the board. We took a decision in the board. This year we just exempt all the female Egyptian female orthopedic surgeons from the conference fees. I hope also in the coming years we will sponsor all the residents and specialists, not the professors, women's orthopedic women's in the conference, and we are ready just to send this message to all females. Anyone just wants to join the orthopedic programs and she needs support from the board, we are very happy to do that, and we will do all support for women who wants to join the orthopedic program. شكرا جزيلا. We conclude these sessions and we took like 29 minutes from the coffee break, so we'll start the next session. Thank you very much for attending this session. Martin? Yeah, we can just delay 5 minutes if you want.
Yes, no.
She's only passing. We just pick her.